So I've done clinical insight training for ad hoc before, and then I was asked to do some clinical insight training for the duty desk. So it is aimed at non-clinicians, but it's basically to try and give you a bit of information behind what we do. So I've created these packs for you, and in it has the slide that we're going to do, notes that you can make if you wish, but also examples of Tanner searches, so you can keep this. It's also got a lot of information about different niches, and then at the end we'll do a little bit about community, a few of their slides. Nikki Peters checked the Tanner searches for me because I'm not the best, and she was happy with them, so if they're wrong, that's Nikki Peters' fault. I'm not the best at Tanner searches. So. Right, so we'll do kind of half of it, and then we'll have a 10-minute break, because otherwise it's death by PowerPoint and I lose my voice. So what we're going to talk through is that entire list there. I'm not going to read them all out. So the oncology, we're going to be covering a bit of the chemo niche, mental health. I talk about the different types of sections that our patients come under. There's hundreds of sections, but we've just focused on the ones that we see a lot, just to kind of have a bit more information. And then the clinical insight is, we talk about different pieces of equipment, etc., that you might come across on your phone calls. So, types of ward. So medical, there's all different types of medical wards. You have the general medicine, which is a less fast-paced environment than the acute medical units. So we have ACMED and MED on the Tanner searches. So basically we wouldn't want to put a med nurse into an ACMED environment, because they just don't cope with the pace of the workload, and we get a lot of incidents of nurses that go into acute medical and then they can't keep up with the demands that they need to. And also when you're thinking sort of general cardiac, that comes under medical, so that's patients with issues with their heart, but are pretty stable, so don't need a kind of higher intense care. And then respiratory, so patients with breathing problems, asthma, chronic obstructive pulmonary disease, infections, cystic fibrosis. So cystic fibrosis is quite an interesting one, because probably 15 years ago, people with cystic fibrosis weren't hitting adulthood. They're generally teenagers, early 20s potentially, without heart-lung transplants. But now with modern medicine and how they're managed, CFs are actually going up in 50s and 60s, some of them. So adult services have had it, basically the cystic fibrosis children, when I was working in the Children's Hospital, would stay with the children's services until they were sort of 24, because generally they wouldn't survive much past it. Whereas now they're having to go into adult services. So adult services are kind of getting their heads around that condition. And then neurology, sort of patients with neurological conditions, so issues with their brain, basically. So there's all different types of medical. And in your pack, you've got Tanner searches for beds. Surgical wards, again, there's all different types of surgical wards, and we'll go into theatres a bit more later, because there's 50 million Tanner codes for theatres. But again, they're all different types of surgery, and some surgical nurses will be very used to working in one surgical area, but not so much in another surgical area. A lot of nurses don't like day case surgical units, because again, it's fast paced, it's a lot of paperwork. You admit the patient, you do make sure they're all consented, check all the paperwork, take them to theatres, pick them up from recovery, do some obs and discharge them home. Whereas the more other surgicals are more kind of long stay. So general surgery, people who require appendicitis or kind of a bit of abdominal surgery, just nothing kind of that's specific to another niche. Urology, problems with their bits, I was trying to say that without swearing, or their urinary tract. Gynecology, female patients' bits. trauma and orthopaedic, so surgery relating to trauma or broken bones. A lot of people don't understand that if you break a bone, your bone bleeds really badly, and you can actually bleed out from, if you break your pelvis, you can actually bleed to death within the hour, because they bleed a lot, which is when you hear about the golden hour, people talking in A&E, that's that to stabilise the treatment to stop them bleeding out. So yeah, people think, oh, broken bones, they'll just go and have a plaster put on. But actually, yeah, it's quite a dangerous injury.
They said with people that get into car accidents, especially if you get your steering wheel hits you around sort of the pelvic area, that you're not supposed to move that, are you? Because effectively what it's doing is
It's stemming the bleeding.
It's stemming the bleeding. So as soon as you remove that,
They can bleed out.
You effectively bleed into your cavities within your body.
Yeah. And the difficulty with broken bones, particularly in children and sort of younger people or middle-aged people, is that you compensate. So your body protects it by changing your blood flow to different organs, and you become quite stable, and then you drop off because you can't compensate anymore. And kids very much so compensate, and then they'll just drop and they'll go into some kind of arrest situation. So when you're thinking about broken bones, it's not just your simple thing. It can be quite a dangerous injury. So neurosurgical, so patients who require surgery on their brain, spine or nervous system, that's quite specialised, particularly with the observations afterwards, because it's sort of very neurological orientated, and you have to know what you're doing to interpret it. Vascular always fascinates me. How they can operate on arteries or veins fascinates me, but it's so intricate, and you can always tell a vascular surgeon because they've got binoculars like this long, so they can see the micro bits and chop bits out and stitch it back up again. And ear, nose and throat says what it does in the tin. It's all about your ears, nose and throat. They're not, there's a national policy now that adults, they won't remove tonsils unless they really, really, really have to, because the recovery's so rubbish. I was born without mine.
Were you? That's interesting.
So clever. Or special.
With all of the different wards,
Yeah.
so if we're sending a nurse into like any of those wards, are they actually present when the surgery's happening?
No. So this is post-op. So when the surgery's happening, there's theatres.
Okay.
So this is the wards that they look after them before their operation and after their operation.
Okay, so if we sent a nurse to ENT, they'd either be looking after someone who is just about to get an operation
Or afterwards.
So what's theatre recovery then?
So theatre recovery is when you come out of anaesthetic.
Okay.
So you have your anaesthetic for your surgery, and then you go to recovery to have your airway managed and come out and make sure you're nice and awake.
After that you
go to the ward.
back to one of them.
Yeah,
Okay.
unless you're really poorly and you end up in intensive care.
Okay.
It's dependent. But yeah, they're all ward-based
Okay.
environments. So they tend to be surge on the TANA code.
So when people say general ward, that's just kind of where there's like loads of patients that are...
With all different types of surgery.
but-
Yeah.
Okay.
Because what you'll find is in the smaller hospitals, they won't have wards for this, wards for that, wards for the other. They'll have sort of general, sometimes they even have general female, don't they, and general male, where they all go in together.
Okay.
Whereas the bigger hospitals tend to specialise out.
Okay.
Gynecology tends to always be separate, and that generally is attached to sort of midwifery, maternity. Right, there you go. So trauma and orthopaedics, I've already talked about this. So people that would go in for bone surgery as a kind of, not a non-emergent situation would be people having hip replacements, knee replacements, back surgery, bone surgery for cancers. So it's not always an emergency situation. The trauma wards are sometimes some hospitals have trauma and orthopaedics together, some have separate. So the trauma is when you've been involved in a car accident, or you've fallen off a horse, or whatever you've done. Skiing, big one.
Bicycles,
Yeah,
motorbike.
yeah,
So they go to A&E first and then they go to trauma.
Yeah. yeah.
But they lump them together because they would tend to have had an injury,
Similar.
like an orthopedic injury.
Yeah, generally, yeah. So the kids that we had in intensive care are slightly different, but that have been in trauma instance was, we had a joyrider who stole a car and totaled it, and he'd basically broken both his legs, he'd lacerated his liver, he'd got a head injury, done all sorts, but so that's trauma related. And then
what would you do in that situation though, if someone was in a car crash and they like seriously injured their like brain or like loads of different things, like
where would they go?
if the injury was over several, like could be treated by several different wards,
Yeah.
what would you do? Would you have to like
So if they're really ill,
prioritise something?
if they're really ill, they'd end up in HD or intensive care.
Yeah.
If they weren't so ill, then you would prioritise the one that's most dangerous, that could kill them the most.
So a nurse going into trauma and orthopedics would probably have experience with like a wider range
of stuff. Yeah.
And know how to
Yeah,
prioritize.
hopefully.
Hopefully.
And we wouldn't reference for that, would we? Specifically or not
It's
necessarily?
under surge, isn't it?
Under the surge.
And also.
You have to see
Yeah.
if they've got experience and stuff like that.
And
don't you?
it's not the nurse that prioritises, it's the
The
doctors
doctor.
who
Yeah.
will decide
Okay.
where the patient will go.
But if they went to ITU, would they kind of go from there? Do you know what I mean?
Yeah,
When it
so
comes to going to theatre?
when we had them in ITU, so their main person that would care for them would be the intensivist, which is the doctors in intensive care, and then the other doctors would come and
Make a
come and
judgment,
see us
yeah.
and see that. But they'd be very focused. So we'd have the renal doctors who would only care about the kidneys,
Yeah.
wouldn't care about anything else, or the orthopaedic doctors that would come in and they'd want to know why aren't they elevated, and you're like, well, they've got this and this and this,
Yeah.
and they were like bones.
Okay, but you have loads of different doctors and the nurse would just prioritise and making sure that they're obviously
And
stable.
following the care plan.
Okay.
Yeah, following what's needed.
Yeah. Alright.
But yeah, it very much depends on what injury they've got as to what post-op care they would need. Geriatrics, well apparently we're not allowed to call it geriatrics anymore, but I don't know quite how. So to me, geriatrics is like paediatrics, just larger nappies. So yeah, so the care of the elderly wards generally are combined, so they'll have medical and sort of surgical concerns. So it's with people with dementia, infections, say fractured bones because they fall out of bed and fracture their neck or femur, or respiratory problems. Interestingly, if an older person comes in who's completely lucid before and completely self-cares and comes in and they're completely doolally tap, generally it's because they've got a urinary infection. It sends them loopy, doesn't it?
Absolutely, like hallucinating.
Yeah,
Yeah,
completely.
absolutely. Yeah.
It's crazy. But,
This is where a lot of bed blocking will happen, right? People that come in independent and then
can't,
go home.
yeah, and then there's no place in nursing homes, and by the time they've been CHC assessed, and it just takes
Very true.
forever and ever. Did anybody watch that drama Care that was on
Oh
IT?
God, I've heard about it. I haven't watched it.
It was really good.
Yeah,
with,
I've heard. Really intense.
what's the place? Sheldon Smith.
Yeah.
Amazing. All about her mum and dementia and how she had to fight the CCGs to get funding, and because they wanted her to go to a home that was poorly managed because it was cheap, and how she got into the home that she wanted them, and yeah,
Wow.
it's good, worth a watch.
I'll watch it.
Was worth a watch. Emergency department. So we get loads of shifts, don't we, for A&E at the moment. So they're the different departments in ED. So ED, it's sometimes ED, sometimes A&E, sometimes accident centre, depending on what area of the country you come from. In your pack, I've actually put links from Southmead Hospital that gives you information of the different types of departments from a patient's perspective. So it's quite useful.
When a
Useful to
nurse
read.
has triage, so like a nurse could have A&E but not triage on
Yeah.
their skill.
Yeah.
So what's the difference between a nurse who just has A&E and a nurse who has A&E
So-
and triage? What can that triage skill mean that they can do?
Yeah, so triage, you have to do an additional training.
Yeah.
So basically it gives you the skills to assess a patient and to work out what treatment they need and how quickly. So it's more responsibility. So A&E
That can
nurses,
help the hospital a
Is that
lot
like a
more.
header? what you had used to do, with medical
Yeah.
reasons, yeah.
So generally you work in A&E and then you do your triage course, and then you can triage afterwards as well.
And any observations as well in nursing, yeah.
So the A&E is like on the observation ward, which you can generally give a acute med to as well,
Yeah.
where they're waiting for test results, or they're waiting for admission to hospital.
Okay.
They can be in there overnight, or 2
Okay.
nights, or 3 nights.
So a client requesting an A&E nurse, unless they specifically requested triage, wouldn't necessarily expect every A&E nurse to
Yeah.
do it?
There's generally, hospitals wouldn't want to use an agency worker in their triage.
Yeah, transfer.
Yeah. So when I was working at the Children's Hospital, if A&E was short, close to working ITU, we would go down, but we'd only work in resus because it was more about the airway management, etc. So if we can't find an A&E nurse and they're desperate, we can always say, well, we could probably find you an ITU nurse to work in resus, but it's on the client's say
That's
so.
good to know. We tend to just say we could get you an acute medical nurse, but I never thought about ITU.
Yeah,
That's
if they wanted.
Yeah.
Because all the equipment's the same. The transport ventilators that they tend to use in A&E are the same as the transport ones in ITU. So that is an option.
Yeah, so
But-
they've got sick patients and
but, yeah.
med nurses in enough.
Yeah.
That's another option. That's good to know.
And then as long as they say yay, then
That's what they
yeah.
And obviously that's what they only do that.
Yeah, absolutely. Absolutely. And when we get some A&E nurses that can only do minors, or some that can do all of it. So
Do we ever have a situation where, you know, like when you actually first go into A&E and you're waiting for someone to see you?
That's
and actually,
triage.
That would be when you're literally, as soon as you walk in, you're in
Yeah.
the waiting area.
And then
the
you get
nurse
called
kind of
into it.
walks around,
Yeah.
yeah.
that's triage.
Okay.
So that's assessing how poor
And then
you are.
obviously they'd either direct you to one of the or below.
Yeah.
Okay.
Yeah, unless you're ridiculously sick and you come in back of an ambulance and you go straight in
Yeah.
to whatever. But,
Amazing.
yeah,
Most likely.
but a lot of people, I was watching at the documentary Ambulance, and they were saying that a lot of people phone 999 because they think the ambulances are going to take them straight into the department and they'll get seen straight away, as opposed to going and
So
sitting in the
surely
waiting
the
area.
paramedics will assess you while you're in ambulance as well.
They do, and then they chuck them into the waiting room. But they think it's a way of stopping the wait. But yeah, I mean, A&E is quite a stressful environment, because you don't know what's going to come through the door. You don't know what's around the corner, and it could be, you know, empty and then jam-packed full. Particularly Saturday nights with all the drunks and. But I think they've reduced, haven't they? They've reduced the drunk admissions because of the buses that they're using now. I can't remember what they're called. Drink buses, drink buses, or what? Yeah. No, it's a bus that goes and sits in the city centre, and it will treat people who've got minor injuries or are just
Drunk
pissed.
injuries,
Yeah. And then they'll chuck them out. As
That's
opposed
such
to,
an idea.
they've got little stretchers and they have whatever and IV fluids and.
Drunk people, I feel for A&E nurses on the weekend.
Oh,
Like, it's a hard
Yeah.
enough job, and if you've got someone that's irate. I've had a friend that's gone in against her will with a massive head wound, and she like hijacked a wheelchair and was doing wheelies around the department. Honestly, it's so bad.
So intensive care and high dependency. So I put the two pictures in just to kind of show you what an intensive care nurse has to look after. With all the different equipment, all the different sort of infusion pumps, the amount of drugs that they have to give, because when you'll find that when you're speaking to ITU nurses, they come across as quite arrogant and quite stroppy, and that's because they're bred to be arrogant, because you'd only ever be able to cope with that level of care if you had something about you. And I'm an ITU nurse, so I can say we're arrogant. But that's how we were brought up to cope with the environment we were in. Although I'm not too arrogant.
I used to do that until
That's
I left it now,
But you just
actually a HD.
but you look at it and you go, ooh.
Yeah.
And I watched a programme a few weeks ago, and they had an ECMO circuit, which is basically heart and lung bypass, and then they had to piggyback the hemofilter and kidney dialysis onto. I was like, oh, yes.
If there was like an old person who was just at end of life in a separate ward, would they
Yeah.
immediately be in intensive care?
No, set end of life
Sometimes
separate.
if it's like going to happen.
Yeah.
And that would be for people who are like treatable, that's literally on the edge.
Yeah, yeah.
So a heart and lung bypass takes the blood out and pumps it
And oxygenates
to
it
give it an
and
oxygen.
shove it back in.
Wow.
Yeah. ECMO. Yeah.
Things they can do.
I know, it's crazy, isn't it? It is crazy. There's different types of intensive care. So we had an issue recently with the ad hoc team who thought ITUC was children's, which you would because it's C.
Yeah, it makes sense.
But it's-
paediatric.
Yeah,
But
We have that with P, there's sometimes it's psychiatry, sometimes
Exactly,
it's pediatrics,
yeah.
so it's the same
Yes.
abbreviation.
Yeah.
Yeah.
Different
You have to be
hospitals
careful,
abbreviate
yeah.
and that's the problem,
Yeah.
because different hospitals don't talk the same language that we do
No.
internally, do they? That's the problem. You
No.
think,
yeah. And you'll find that the bigger hospitals will have separate ITUs for various different conditions, whereas the sort of the DGHs, the district generals, will have just one intensive care for all. You'll find that the adult intensive care nurses, generally, if they're working in a big hospital, they will specialise in general or cardiac or neuro. And it is, when you're that specialised, quite difficult to transfer between them. So neuro intensive care is for people with head injuries, so they'll have drains coming out of their head, they'll have pits of skull removed, they'll have pressures in their brain that you monitor and have to tweak
What do you do
medications
as a nurse, like in that situation? Like I've never actually known what they actually have to do when they get there, like change those tubes and stuff
They
like that.
have to, not necessarily, no, the neurosurgeons would change the tubes, but they would drain fluid if the pressure's gone up too much, and if they drain too much fluid, then the brain sucks down into their brain stem, and it's really high intense. And there's always medical staff on the unit, always, but you know, you end up in charge of your patient, and you end up doing most of the care, and you can prescribe a bit more in intensive care. You're much more holistic in your approach. In PEDS ITU, we used to get the adult registrars for adults, and when they'd come to work with us, they'd have to work as SHOs because they weren't used to children, and they used to hate it. They were right arrogant.
Take them down a notch.
Oh, absolute arrogant sods, they really were.
Children react differently to things.
Yeah.
Adults, to a degree, are bigger, so therefore you generally get lines and bits and pieces in. Children, you get
Dinky dots.
Also, I've had nurses comment on that it's not just the size, there's just completely different ways the body functions.
Oh, yeah,
Yeah.
The way you ventilate a child is very different to the way you ventilate an adult. An adult, you're ventilating generally with volume, so you set a volume, the amount of push into your lungs, whereas children, because their rib cages are soft and their lungs are slightly more friable, if you pushed, what used to be 0.5 mils per kilo or something, straight in, then it would just pop because it wouldn't stop.
Explode their lungs.
Yeah, so you have to have pressure, so you'd have a top pressure that wouldn't, so it'd deliver as much volume as it could until it hit that pressure, and then it would.
So do they
back
do a
up.
higher oxygen content when they're ventilating?
Children, depends. If they're cardiac, then no, but no, they're generally quite good at weaning off. Yeah.
Would any of these guys also work in burns? Because obviously that would be another
Yeah,
speciality.
yeah,
Because
yeah.
again, that would be, dealing with a burn is very different to dealing with brain.
It's the
Would that be an intensive care?
yeah, you can have a. I think it's ITUB actually. I think
Yeah.
put on there.
Yes, you could source the, you have to have this to French.
It is, yeah. Southmead, because the burns for kids went to the children's hospital. But I think it's the only time I vomited at work was looking after a burns patient. Yeah.
What, how bad is it? If you go into ITU for burns, is it like absolutely
Oh,
horrendous?
yes. Yeah. So I looked after a little, how old was she? 7 months old. She just moved to a council house in Taunton, and the cold water tank hadn't been serviced, and it heated itself and exploded all over her cot. And the only bit that wasn't burnt was her nappy area, because obviously that's where she was wearing her nappy. And she was like a little alien. That's all I could.
What is that bad?
Well, she had no skin.
Does she survive?
No, thankfully. But she, you couldn't have any monitoring, so there was nothing to stick stuff to. All her tubes were stitched to her lips or her nose because you couldn't stick anything because she had no skin. and she then they then took her nappy area as part of skin graft, and then she got infected, and that's when I puked. But I've also looked after we looked after a little boy whose 2-year-old brother set light to his cock because his parents were off their case on all sorts, and he burnt his little willy off. Bless him. But then I've looked after a 14-year-old who her and her mates in McDonald's in Brislington decided to inhale impulse spray to get high, and then sparked to get high, and then sparked a cigarette up and blew McDonald's roof off, and she blew her face off and but she had pig skin, and you couldn't even see she had a burn, even though she burnt her entire face. Yeah, and then McDonald's sued them for their roof. So yeah. But anyway, I'll carry on with my stories. So intensive care, and then your step down from intensive care is high dependency. So in intensive care, it generally is 1-to-1, so one nurse, one patient, or sometimes 2 nurses, 1 patient if they're really, really sick. Whereas HDU is the opposite, it's just 1 nurse to 2 patients generally. So the main rule that we need to remember for us non-clinical peeps is that ITU nurses can work in HDU. HDU nurses can't work in ITU.
You can obviously offer it.
Yeah, because what they might find is if they've got an HDU patient on intensive care, then they give them that patient.
So they just use a little bit less equipment.
Yeah,
they're less
and they're not.
demanding.
Yeah, they're not on the vent.
Okay, that's like the biggest difference.
Yeah.
HD's not on the vent.
Yeah, generally.
A tracheostomy or something
They
like
do.
that. And you can choose.
Or
Lots
in
of
our
monitors
monitors.
in HDU.
They have a
They're
tracheostomy.
waiting to go to HDU to ITU, and they come with ventilation. They might just have a tracheostomy, and then so the step down gradually.
Is it likely that all ITU nurses can do?
Trachees generally.
And what's the other one?
Because adults, you trachea really quickly, don't you, compared to peds?
Yeah, I mean, sometimes people come off the ventilation, they don't need one, they might just need an oxygen mask, or they need a cannula, but another times they might just have a tracheostomy for a while, and then they gradually reel it off in HDU nurses. ITU nurses, the HDU nurses sometimes can work in ITU, but obviously they don't need as many skills.
If you had a
then.
HDU nurse with tracheostomy, then it would be, they could,
You'd have to ask the client. Yeah, because if you couldn't find an ITU nurse, then they'd rather have an HDU nurse than no nurse at all.
okay.
But they need to be aware that they need to be given the HDU patients as opposed to the really sick ones.
Yeah. So when they have the tracheostomy, are they getting a separate oxygen supply to that, or is that just to aid their airway?
Generally it's oxygen
So
fire,
just
isn't
like
it?
humidified oxygen, maybe,
Okay,
depending on what
yeah.
type of surgery they tell us.
Yeah.
Just one of the,
So, NICU and SCBU is kind of fairly similar to intensive care and HDU. So you've got NICU, which is your neonatal intensive care, so that's for your really sick babies. They can be preterm or they can be really sick at birth. I hated my time in NICU, absolutely hated it,
Why?
because they're see-through.
I really want to be a neonatal.
The babies are
And everyone
see-through.
says, no, don't do it. But
And you obviously you care for them, but you can't do, so like for me, nursing was all about doing all the personal care and making them all kind. You can only do that every 12 hours on a, you're not allowed to touch them.
And the parents are totally freaked out.
They are.
So you've got that
As
kind
well.
of
I
around
would
watching
find it
everything
more
they do.
depressing knowing that someone's given birth, thought their child was fine, and then all of a sudden something horrendous has happened to them, and then looking up and then. Whereas I feel like the parents are already kind of in that situation where they know their kid's really ill, and
They
all
know
you can
something's
do is
coming.
try and support them to
Yeah.
stay alive.
Yeah.
They're kind of prepared for the worst, do you know what I mean? Whereas if I was like a peds nurse and all of a sudden like a kid comes in and they've got burns and like the parents like absolutely distraught, wasn't expecting this to happen earlier that day.
Yeah.
I don't know.
So it was like
Skaboo
intensive
step
care
down
NICU.
from that then.
Huh?
You know, so you get Skaboo nurses, that's special care
Yeah.
for babies.
Yeah.
So that's a step down from that.
It is, yeah. Well,
So
probably
then
2
they
step
wouldn't
downs
have
for
a
that.
ventilator.
No, they're just feeding and growing and blood sugar, tube feeding.
My friend gave birth 10 weeks early last year.
Wow.
And I've never, he was like £3 or something. And I was still pregnant, and you could feel the baby hiccuping, and then you could see, it seems like such a strong thing for such a small thing to do. And then I saw him hiccup, and I was like, oh, that's why, because their entire diaphragm
You don't.
just like
Yeah.
fits together.
Like shakes their body, doesn't it?
Yeah.
What's the step down from NICU then?
So you've got NICU, you've got some hospitals now have NICU HDU. So St Michael's, for example, they've got 3 rooms. They've got an intensive care room, they've got the HDU room, and then they've got the SCBU room. So it can all be in one department. Whereas Cheltenham and Gloucester, I think Cheltenham's got NICU and Gloucester's got SCBU, I think, from remembering.
So if a patient comes out of NICU in Gloucester, they send them to Cheltenham to be on SCBU. Would they transfer them
They
to
transfer
a different
them,
hospital?
yeah, they do.
And so with SCBU, because it's not necessarily neonatal, it's special care baby unit, can kids end up in there that are infants, that don't go there directly from birth, but end up in hospital needs?
No, so they'd go
They
to
would go to
intensive
PCU.
care.
That is like
Yeah.
straight from birth.
Yeah,
This is always when they've just been born and they
Yeah.
haven't left the hospital.
because once you've left the hospital, once you've left NICU, you're not allowed back
Oh,
because of
right.
infection risk.
Oh, yeah. Yeah.
So I went down to Plymouth to pick up a little one who I think he was born at 26 weeks, had done the whole thing, had got on really well, gone home, hadn't been home for 12 hours and went down with meningococcal meningitis. And they actually readmitted him to NICU, and everyone was freaking out because he was obviously in a box, and then we had to take him out of his incubator to get him because he was so sick. But yeah, and generally they're not allowed back in
Yeah.
through the doors. See, look, there's some feeders and growers. And they're hilarious. You can pick them up with one hand and go, there, they love me.
What can you do more in this one than in SCBU? So you can actually care for
You
them?
feed them, change them, cuddle them, dress them, bath them. Right, theatres. So, if you've never worked in hospital before and you think about theatres and where people are going to go and have their operations, you don't think about all the different types of theatres that are available, basically. And in each different type of theatres, they use different equipment, they have different procedures, so which is why we've got all the different types of codes for scrub. So we have general cardiac, neurological, orthopaedics, they've also got burns, ENT, all sorts of different types of theatres. And then they run different lists, and you'll find in some hospitals that, so the burns theatre is literally set up for burns. So only burns patients go in there or overflow if needed. Cardiac, exactly the same, different cardiac theatres. So there's a phase with any kind of surgery, what we were talking about earlier, Bella. So you've got your pre-operative phase, your operative phase, and your recovery phase. So your pre-operative is where you're admitted, you have your consent form done, the anaesthetist comes and has a chat with you, tells you about the anaesthetic, you sign to say it's all fine. And then they get taken to theatre. And then you go into what's called anaesthetic room, so where they put you off to sleep. Anaesthetics, so we've got different codes, cardiac, neurological, orthopaedics.
Yeah.
So, and then so for example, some medications are given to patients with cardiac conditions to put them off to sleep, and some are given to others. So in cardiac, you want them to go off to sleep really quickly, so they tend to give what they call a rapid induction. And one of those drugs is called succinylcholine, which paralyses you. If you give that to a burns patient, they go into cardiac arrest immediately. It just doesn't. So it's different drugs of how they do it.
Well, that's the NU one.
That's neurological, but there is a burn. Must be a burn, maybe not.
So anaesthetists generally are doctors, aren't they?
Yeah.
They are supporting nurses.
Yeah.
Yeah.
So, what
So
does
the
nurse do
anaesthetist
to
would
support?
actually put them to sleep, but
Yeah.
the nurse needs to know
Just all the drugs.
the
and
type of drugs
yeah.
they use and the reactions they could have and what to look
Yeah.
for with their
Yeah.
blood pressure and stuff.
Yeah. And you might actually find, when I did my EMB 4 and 5, I spent 3 days with anaesthetists, and actually he let me intubate, he let me do everything. So they do allow to.
Would the anaesthetist stay with that patient through the surgery?
Unless they're getting a cup of tea,
All right.
and then the nurse will stay with them and monitor.
Yeah.
So nurse provides other drugs. And
A little hand equipment and etc. Put all the monitoring on. But yeah, it depends on where you're working to what kind of process you
It
follow.
depends on the hospital as well, doesn't it? Some hospitals will have a circulating nurse that does it all effectively, but some nurses want these individual.
Skills. Or a lot of hospitals phone up and don't actually specify what they want from a scrub nurse.
Yeah, but it's important that we get that information
Yeah.
because
So different. So once they've had the anaesthetic, they've had their airway secured, they're all ready, they then go into theatres and so the anaesthetic team stay with them, but they have another team in theatres that do the actual surgery. And that's where you've got all your loads of your scrub codes.
So an anaesthetics nurse will be in the theatre while they're doing it.
Yeah.
So they technically do scrub in, but they don't scrub in to the point of hands
so they're
in.
sterile, but they're not. Yeah,
They're not hands in doing
No,
business.
no. Which is why an anaesthetic nurse doesn't have to be EPP. Yeah.
Yeah.
Whereas the others do. So yeah, there's all different types, and the reason is because it's all different types of surgery. They use different equipment, different procedures, and the surgeon will expect that nurse to know exactly what they need at what point. So if you send a gynae scrub nurse into an ENT, completely wrong end of the body, God knows what they shove up their nose. It can be quite painful. And then you've got your next level better, which is your first assistant. So surgery, there's always two surgeons. Surgeon 1, which is the main one, then surgeon 2, which is the assistant. Some nurses, who are called first assistants, can help be the second doctor.
So I've had a request from Bupa at the Spire in Bristol for a first assistant.
So when you've had your surgery and it's all completed, and you're well enough to go to a ward, not an intensive care unit. In order to recover from the anaesthetic, you go to recovery. So it's a room with 6 or 8 beds, and they come in generally with their airways out or with their airways in, and they are looked after until they're awake and with it again, and can support their own breathing.
So patients always intubated when they go into general surgery? Under general anaesthetic?
Generally, yeah. So it'll be either with with an ET tube, which goes between your vocal cords, or with a LMA, which looks like a tube looks like a big tongue on the end. That
I've seen that
I
one.
know how we've gone through all that. I know we haven't got chemo nurses yet, but if there's like a patient that is suffering with cancer, what do they do? Where do they go?
So they go into oncology theatres or general
What's
theatres.
oncology?
Cancer.
Oh, is it?
Yeah.
So that's like a special ward that they go to.
So it's now a theatre.
And then then they go to the theatre and have obviously
Whatever surgery.
Yeah.
Then they'll go to recovery. Then they'll go back to the oncology ward.
Okay.
Yeah. So in the past, as an ITU nurse for Thornbury, I've been sent to do recovery at the Spire. So sometimes if you can't find a recovery nurse, they're happy with an ITU nurse. I went to recover the children as an ITU peds, and we didn't have any children that day, so I ended up recovering adults under a supervision of a...
What's an endoscopy?
So an endoscopy is a tube
Okay.
that goes down to have a look.
with the camera.
Or up your nose.
So yeah,
Very painful.
And what about if where do they fit into it if they have a colostomy bag?
Well, they still go to theatre if they need to go to theatre. It's just they come out sometimes with a colostomy bag, so the bowel's brought out to the...
Oh, right, okay.
with endoscopy, so this is one that confuses me. So there's endoscopy where they need someone that's surgical, like they're going to go in and do an endoscopy procedure and they have to have the surgical experience to do
Yeah.
it. And then I think there's been a time in the call centre where there was an endoscopy on a ward and they said they could take a medical patient.
Was that because overflow? When they're using endoscopy for
Sometimes
overflow?
they use the endoscopy units as for general medical patients if they've not got enough beds in the hospital. Not
Okay.
always, but
Because
sometimes.
the way it was
they do.
explained to me was that maybe sometimes endoscopy is related to medical conditions,
Well, it can
and
be.
they'll do an endoscopy
And go back
to
to medical.
investigate, but they're there for medical complaint.
Yeah, because if
Okay.
they've got ulcers or anything like that. But I know very recently they've been using it as an overflow, haven't they? Because we had a bit of a panic when we saw medical nurses being put in there.
Okay.
But generally the client should know what they want.
Yeah.
If it's out of hours or at weekends, then it's usually overflow,
Okay.
because it's a
They won't
routine
have booked it in.
procedure, so they
Yeah.
won't book in
That's
out
good
of
to
hours,
know.
yeah.
Okay.
So we've already discussed this.
How long is a patient usually in recovery? Not very long.
It depends how quickly they wake up.
But like not long enough to
Hours.
have to do bed changes
No.
or any of that personal care
Well,
stuff?
no, not unless they
It's
will
usually a
themselves.
matter of hours.
Yeah.
But all you need to know is that there's different types of theatres, and we need to make sure if they want a scrub
They
nurse
actually
that we
match
have
up.
the right. Yeah. Yeah.
Quick question, sorry. So these abbreviations, which are SC, are they on the, would they be on when you're trying to control?
On the
what
skills.
shifts would it be?
Yeah. Yeah.
I've taken a few shifts where I've not felt 100% confident. This is really helpful to know. And I've just taken as much information from the
Fine.
as possible and
Yeah.
just write it all down and then hope that the niche's people
And
have the information.
and sometimes the people that phone up for the shifts don't know what they want either.
Because if it's a nurse bank, they're not often nurses.
No.
Yeah.
So it can be tricky. Cardiac, so problems with the heart. So there's 3 different types of cardiac settings in the hospital. You've got your cardiology ward for less acutely ill cardiac patients. You've got coronary care unit, CCU, which we get quite a few shifts for, and therefore patients who are more acutely unwell with their hearts and need a lot more sort of monitoring. CCUs tend to have central monitoring, so at the desk you'll have all the patients' monitors. So if people have had a heart attack and they need sort of more intense treatment, they go to CCU. If they've had kind of cardiac stent surgery or anything like that, then they can go to CCU. And then you've got your cardiac intensive care, so the people who are really, really poorly.
So sometimes clients ask for a general trained nurse for CCU and sometimes they ask for a specialist CCU nurse.
Yeah,
Would the specialist CCU nurse be sat doing kind of
they do the more intense
central
patients.
monitoring?
Yeah,
And then the general
would just be with
ward
less.
nurse
Yeah,
doing ops and stuff?
Yeah.
Okay.
yeah, or if those patients are waiting to go back to the cardiology
So
ward.
they don't have to have the CCU skill?
If they ask, yeah. So it's always worth asking, do you want a CCU trained nurse or a general nurse?
But then they're normally medical nurses if they go
Yeah.
and do it.
Yeah. So cardiac intensive care, so patients that have had triple, quadruple bypass surgery, they often go into CICU for the first few days. If hospitals aren't big enough, then they won't have an ITUC, they'll just go to the general ITU.
So they have had surgery for this. They'll be recovered within an ITU kind of setting.
Depends, if they're poorly enough for them to remain sedated and ventilated, then they'll go to CICU or ITU. If they're able to be taken off the breathing machine, then they'll be recovered and then sent to...
And they'll go back, and they're still sent back to a CCU as though it's a medical ward.
Yeah, or a surgical HDU, depending on the
Okay.
hospital.
Okay.
They all have different room
Sometimes
types.
these like boundaries blur
Oh,
between med and surge.
completely blur,
Just get
completely.
If you're in a city, all the hospitals have obviously big units, don't they? But when I worked in Dorset County Hospital, it's General Hospital, down near Weymouth, so you had a bit of everything. Or they got transferred to Southampton or Bristol if they had really
Yeah.
physically unwell then. But you sort of covered a bit of everything on the
Yes,
units
you have to
there,
have
so.
really broad knowledge.
Whereas they're so specialised in Bristol, they're lucky.
Yeah, but you find that the nurses that work in the DGHs have got so much more experience though, because they do a bit of everything
Yeah.
and not so much just cardiac. And I used to love looking after the cardiac patients. They were such a challenge. I had one little lad who he had a truncus arteriosus. So basically, when your heart develops, you can see on the picture the two main chambers. With truncus arteriosus, because basically they split in utero, and with truncus they don't. They just have one
big
vessel.
chamber.
Yeah. So they have the hole in the heart that circulates your blood, so they have to keep that open. And it's a major surgery. So this little lad, he was 2.5 kilos weight, and he had his surgery, and his heart was so swollen they couldn't close his chest. We came to ITU with open chest. He had 46 infusion pumps. He was ridiculous. He was on dialysis. You couldn't see him for the. He had his chest open, I think, about 12 weeks.
Oh my God. And so what do they do with the rib cage at that point?
So it just it's
pulled
open.
apart.
Yeah, and then every time it goes into cardiac arrest, you have to do internal. So oncology and haematology. So you'll find that some small hospitals will have oncology and haematology as a ward together, whereas in big hospitals they tend to have separate oncology and haematology. So the difference, Bells, between oncology and haematology is cancer of the blood and other blood diseases, whereas oncology is cancer but a sort of tumour mass. And then you've got bone marrow transplant. So when people have sort of leukemia or lymphoma, they can have a bone marrow transplant, which is basically when you take your chemo wipes all your unhealthy blood cells, and then you get given new blood cells to make more. And you're really sick. You're really sick with bone marrow
And you
transplant.
can just genuinely, like, if you're a medical nurse, you just know
It'll be oncology nurse.
Some people work with bone marrow transplant this for years, don't they?
I
They might
think
don't.
more specialised in the bone marrow, there might be,
Proper.
not
Is it
just
just
oncology
says
nurse
on the
always
tan,
is that it's very
The
specialised
chemo
in
and-
children and adults, don't they?
They
But-
They do.
And they're often in isolation as well,
For-
so you're in
for weeks.
separate side rooms,
Yeah.
you know.
They're very susceptible to when they obviously
Infections.
because obviously their immunity's gone, isn't it?
Completely
Yeah.
gone, yeah.
So a lot of nurses that go into oncology, even if they're not doing bone marrow transplant, but oncology is a lot of chemo, so they have to be really high occupational health cleared, like.
And they have to have chemo on their skills if they're doing chemo.
Yeah.
But you'll find
We
that a lot of
barely have
oncology
any
nurses don't do
nurses.
chemo.
We were
Oh, so
asked
that's
one the other
specific
day.
to-
How come it just says general trained med if it would have to be an oncology nurse?
Because it's the chemo bit. So a lot of oncology medical nurses can't do chemo.
So would it be the same way that, you know, we were just saying about how you might have a general trained medical nurse with triage? It would be like a general trained medical nurse with like an oncology skill.
Yeah, or in
Or,
chemo.
yeah.
I went into,
Phlebotomy or
I did a 10 and I went
Oh,
into the added skills and I looked up chemo and added that as a skill in the search.
It's hardly any.
There's none, there's none. I think there's 2 nurses. Yeah.
In your pack, you've actually got more information about chemotherapy that Rika wrote for the niches. So that'll give you more information on it. When we had oncology kids in intensive care, we wouldn't do their chemo. The chemo nurses would come down with their big gloves, and they'd come down the ward.
That's
And
for
then do it.
infection
What
control.
do
They
they
just have to
do?
be mega barrier.
And also because of the drugs are so toxic
Oh yeah.
that you don't want it on your
Yeah.
skin, or
And you deal with it all day.
and if they put it on the floor, there's special kits they have to clear up. It's
Yeah.
all special protocols.
What, so chemo's a liquid?
Yeah, generally.
And then you obviously go
But
into
it's
hospital
very
to get your next
toxic.
injections. So what do they do about the patients?
Yeah. Do they get a special line if they're going in for regular chemo treatment? Do they?
So you can have central
So-
lines, Hickman lines, PICC lines, or some adults, if they're having chemo once a week, will go in and just have an IV cannula put in at the time. They can have portacats under the skin. It just depends on
how
depends
much
on
they're
the
gonna have.
oncologist, doesn't it, and what treatment they're on, what they're on.
Yeah.
Yeah.
So the chemo nurse would know how to administer obviously the chemo drugs, but they do some, because people get really sick with it, right? So would the oncology nurse on a ward know how to look after someone after they've had
Yeah,
their chemotherapy?
absolutely, yeah. You can get really sick with it. You can also reject it as well, and it's host versus disease, and Yeah, it's not nice.
People can have heart attacks, can't they, from chemo?
We have all sorts, yeah.
My stepmom really reacted badly. She was
reaction,
ill
isn't
for
it?
years and years and years. And I think they got to the point where they had to slow down the chemo and spread it out because she literally just
Because
couldn't
reacted to it, kind of body,
handle
yeah.
Because it's a case where it's got to kill the cancer before it literally kills
Yeah.
you.
So different types of sort of chemo wards. You've got your chemo day unit where people come in for the day, have their lines inserted or attached, have their chemo, and then they trot off back home again. If they're poorly or they've got really complex chemo regime, then they can be on the inpatient unit. And then you've got a chemo outpatients unit where you can be seen by the oncology team. But yeah, your TANA code is chemo.
What's the difference between a chemo day unit and a chemo outpatients unit?
So the outpatients, you don't actually have your chemo. You go and see the oncology team and have
right.
your
Assessment
blood
and stuff.
blood
Okay.
results looked at,
Yeah.
and then they work out your ongoing treatment plan.
And then you go to the chemo day unit.
Yeah. Or inpatient if you're poorly. Maternity. So you've got your various different departments. So you're basically antenatal before you've had the baby, intranatal when you're having it, and postnatal afterwards.
We don't have any of these shifts really, do we?
We have some midwifery shifts, yeah.
Yeah. My cousin's a midwife, but she was an RGN, and then she
We
did
have
her conversion
so-
to midwifery. But she can't. She's lost her RGN now because of revalidation, because she can't do enough hours.
You do a 3-year training, the same as you would for a nurse, but you become a registered midwife instead, or you can be a nurse, but you do separate training to be a midwife as well.
And you'll see midwife ITP, so your intention to practice. So midwives have to, I think they have to deliver 50 babies a year.
How many?
To 50 to keep their intention to practice up. And they're only allowed to work on delivery suite if they've got the ITP. So you can have midwives with non-ITP, so that they can work. They can work postnatal. Yeah, but if you think you're working full time, you could deliver 2 or 3 in a shift.
Yeah.
That's true.
If they
Or
were-
more if it's
Yeah.
a busy.
Postnatal
Holiday.
awards for mum and nurses.
So a midwife without ITP can work in pre and post, just can't work in delivery suite. Paediatrics. So caring for patients under the age of 18, but generally now under the age of 16. Some children who have got complex conditions, consultants will keep them on the kids' service until they're 24, and then they have to move to adults. In Yeovil, the kids' hospital have normal adults up to 24. And paediatric units are either split into ages or med-surg, but generally into ages. So when I first qualified, I worked on the 0 to 2s, so babies, and then it was 2 to 11 was the children's ward, and then 11 to 16 was the adolescent ward. But 11 to 16 is a bigger gap developmentally than the 2 to 11s. So we used to be full in the winter of respiratory problems, breathing problems. Because babies breathe through their noses. They can't breathe through their mouths, right? So when they know what they can, but they don't, they generally breathe through their noses. So when their noses are full of snot, they have problems. Whereas adults can just breathe through our mouths if their nose is blocked. And we used to put their breathing tubes down their nose so they could breathe normally, and they could still have their dummies. So you'll find as a general rule that RSCNs are able to do both medical and surgical, because generally as part of your career that you do a combination of everything. So that's why we haven't got RSCN med, RSCN surge, so to speak. Types of ward: renal. So there are 70 main renal units in the UK. Patients can be in renal failure for a whole host of reasons, or they could be on a renal unit because they're post kidney transplant. All the codes that we've got are for the hemodialysis, basically kidney dialysis. So hemofiltration is generally used in an ITU setting, and it literally takes the blood out, puts it through a filter, cleans it, shoves it back in. Whereas the hemodialysis is all about removing all of that and toxins and filtering it, backwashing it and shoving it all.
Which is what your kidney would usually do for you.
Yeah, you normally do with toxins.
Okay.
With the hemodialysis, they very generally have the lumps on their arms, which is where their lines go put into the vein and artery, get brought to the surface. And then peritoneal dialysis is a type of kidney dialysis, but it's about putting fluid with sort of high concentrations of salt and sugars into the peritoneum, and then that draws the fluid off it and then it drains it
This is fascinating. I've never heard of this. So they pump some fluid
into peritoneum,
and then
it draws fluid and toxins away
so
from
the blood
it.
just carries on circulating.
Yeah, and then it just
after-
drains it. So
That's really interesting.
So with kids, we used to have it quarter of an hour to go in, half an hour to dwell, and then quarter of an hour to drain. So you'd have to do it by hand, whereas adults have it by machines.
So it goes into the abdominal cavity.
Yeah,
That's
and it just draws the fluid.
That's so interesting.
Yeah. So it's obviously, or your main complication of that is obviously peritonitis, but you don't have the your circulating volume outside your body.
Yeah.
It's handy. PD is becoming more and more popular, and a lot of people in the community now have PD.
So it can be done in someone's home.
Yeah.
Yeah.
So they go to bed with the machine and it does it, and then they get up and disconnect in the morning. Got quite a few kids on PD in the community. And hemodialysis they now do in the community, don't they? They have their own hemodialysis units in the home, and they plug themselves into it and off they go.
Because if they have to do it how many times a week?
Yeah, to go into a unit for 4 or 5 hours at a time.
Yeah, brilliant.
So primary care roles, you've got various different roles of people working out in primary care. So you've got your ANP, your advanced nurse practitioner. Now you can get ANPs in neonates as well, ANNP I think it's called. So basically they have completed a post-registration qualification, so they're able to do a lot more, as in assess, diagnose, treat, prescribe certain medications, so you don't actually have to see a doctor at all. Emergency care practitioner, so these generally come from a paramedic background, but they can be from a nurse background as well, and they're able to assess, diagnose and provide treatment. So they can work in ambulance cars on their own, prisons, out of hours, surgery, GP surgeries, minor injury units, etc, etc. And paramedics, so they're registered with the HCPC as opposed to the NMC, so they are a regulated body, but they're with the Health and Care Professionals Council, that's it. So other people that are also registered with the HCPC are physios, OTs, speech and language, social workers, morticians I think are going to be. Yeah. And then you've got your practice nurses that will obviously work in GP surgeries but also can work in prisons. And they can do all, the immunisations, the smear tests, etc, etc. But Rika did some information about the different primary care roles for the niches, which is in your pack, so you can read a bit more about it. Also, you've got your TANA examples of TANA searches in it as well.
Can practice nurses give like test results? That always has to be with a doctor, isn't it? Because like when people go and get like blood tests, nurses can take the blood, and you do find a lot of time that the nurses are actually better.
Oh, well, they're a hell of a lot
blood
better, yeah.
Than doctors are, but they can't ever give the results.
If they're an advanced nurse, they probably could give you the results, but generally it has to be doctors.
Okay.
Although if they're normal, the receptionist tells you it's normal. Hospice and palliative care. So basically people can choose, when they've got a terminal illness, they can choose to die wherever they want to, really, whether that's at home, whether that's in hospital, whether that's in a hospice. It's whatever they feel comfortable with. there's been lots of stuff in the press about people going to Dignitas recently, haven't they, because they wanted to die when they wanted to die, and I think eventually that will come over here. There is a big difference between an adult hospice and a children's hospice, apart from the fact that one does adults, one does children. The children's hospice, a lot of kids with complex care go to the children's hospice for respite and family weekends, so it's not just about the end phase in a paediatric hospice, it's about ongoing care. And children's hospices also allow families to stay with their children after, for however long they want to. They've got special beds and rooms, etc. And they also do a hell of a lot of sibling support afterwards, so they do have sibling groups, they do sort of lots of care and support for families, whereas adult hospices tend to be that end of life phase. You wouldn't generally go for respite. Whether that will change with the complex care conditions now they're adulthoods, I don't know. But, they've got hospices now in between, haven't they? So adolescents and young people hospices as well. But yeah, it very much depends on what they want to do and where to die. A lot of people generally want to die at home now, don't they? And ad hoc do a lot of that. They facilitate a lot of patients getting them out of hospital for their last few days at home. They do a lot of palliative care stuff. Nursing homes. So there's all different types of nursing homes. Residential, where they're a bit more self-caring, nursing care when they actually required nursing care, dementia care. They're EMI and H, aren't they? Dementia.
Right, this one really confuses me. So, if you are a nurse, you have to have...
Okay, nursing home.
Yeah, but if you're a healthcare assistant, you don't need any additional skills to go into a nursing home.
Yeah.
Okay, so, but then what's the difference between OK nursing home and EMI and, is it NH? What's the difference?
So
between those
EMI and H is nursing home for care of the elderly with mental health disorders, so dementia.
Okay, and OK nursing
Yeah.
home is just to be
So it's usually a psychiatry nurse or a general nurse, but it can be a psychiatry nurse. So a psychiatry nurse can go in on EMI, if
Yeah.
that's their speciality, but they can't go into a general.
Okay, so you might,
Yeah.
so in nursing homes, you can have, in a nursing home, can you have, like in one nursing home, dementia, residential, you can have all the
You can
different
do
types
different
of
floors.
patients?
Yeah, they have different floors
Okay.
of different, yeah.
It's often OK nursing home. You have to have that for a general trained nurse because they might be the only one there. Right?
Absolutely.
So they have to have the skills to take charge.
Yeah, and doing like the medicine management of it is very different. And the majority of our incidents that we get from nursing homes is all around medication management. Particularly in Northern Ireland, we get a hell of a lot of incidents from Northern Ireland. It's all about medication management. And actually, when you break it down, because we track multiple incidents if it's for the same person or the same place. And actually, it tends to be, when you look at it, the process, not the actual nurses. So they haven't got the processes in place for them to effectively do it properly.
Like check.
Is there
Yeah.
a skillful end of life care?
I don't think there is there?
Or is that,
Or is that
kind of
EOL?
something that you're like
I don't think there
generally
is.
trained for?
You can do a palliative care course.
No, no.
So it might be medical nurses, oncology nurses,
Yeah.
oncology nurses with a lot of experience in palliative care.
So generally, an RGN wouldn't go into dementia care.
Yeah, they go. Yeah.
Okay, and they wouldn't need any extra kind of, when we go to...
Okay,
if a
nursing home,
rings
if it's in.
and it's on a dementia unit for a nursing home, when the nurse pops up and you can see their skills along there, you wouldn't be looking for anything in particular, unless it was EMI nursing home.
Yeah, or OK, or you'd have OK nursing home or home.
Yeah, older psych, wouldn't you sometimes?
Old psych, yeah, old
older
psych.
Maybe.
Because
But
that's
if
the old
you
one,
have a
isn't it?
nursing home that's got a mixture of general and EMI patients, could your resident, OK nursing home would still cover that person to be able to
Yeah.
manage that situation. They kind of look at that whole picture.
Yeah, because sometimes you'll find that they'll request an RMN or an RNLD, not an RGN.
if it's like very heavy on the psych.
Yeah.
Yeah, that's the time to just ask more questions. So you're looking for a psychiatric nurse or a general trained, and they will be able
So
to
if
tell
you see on the drop down that they do have quite a mix, you just make sure you know.
Or can you take either? I mean, Scotland, they often take either.
Yeah.
With supported living, that's not necessarily in a nursing home, is
No,
it?
it could be.
So if you've got like supported, because we've
be
where
in flats
I
or-
live, opposite, we've got like a manor house that's split into, and it's definitely for mental health, but it's supported living. So would nurses go into? Wouldn't that be like district nursing?
Could be. It could be different. So the block of flats next door to my house is supported living, so they have carers going in. So yeah, all different types of ward units, sections of mental health. We don't supply to all of these, as in like the personality disorder units. We very rarely have any shifts for. So the one-to-one specialling in general hospitals, that's probably outside of the mental health, but that's probably most of our work, isn't it? So what do you ask for when they ask for a one-to-one?
Well, there is a drop down to take you through it. So you're initially asking for the sex of the patient,
Yeah.
the age, so you can see whether it's an adolescent or an adult, the reason for admission, psychiatric history, whether control and restraint is required, and whether they'll take a male or female nurse.
Yeah.
We usually in the day, there's kind of the 4-1, so is there risk of violence or aggression, self-harm, suicide or absconding?
Yeah.
And if they're in a side room.
And then most 9 times out of 10, when you say can I have the patient details, they'll like immediately say like the gender, age, why they were brought in. And I think a lot of the ones we get is they're waiting for like mental health assessments.
Yeah.
And
So they're not under a section.
and then when you ask those 4 questions, I mean a lot of our mental health nurses don't really seem like they even care about what they're going into, but obviously we've had cases, haven't we, recently where the staff got a bit funny when we asked for patient details.
Yeah, they can do.
Yeah.
They can do, because they often think we're asking for the patient's name, but I think if we clarify that very early on, that we don't deal with the names, but we do need to know. Age is very important, what kind of nurse they'd like, and also a section, because that would determine what kind of staff
And I
we
had,
put in.
I had an RMN turn down a shift yesterday because she was like, oh, given all the details, that doesn't feel safe for me and the person I am, the kind of practice I do. So she definitely needed to know all that stuff.
Yeah, the more details we can get, the
Well,
better.
CNAPSing, that's child and adolescent. So if they've got child protection level 3, you can't still send them in, they've got to have CNAPSing.
But not all RMNs
Not all,
have that,
no.
do they?
But it is a matter of passing that information on.
They don't have CNAPSing, but they have child protection level 3. And most of the time they have child protection level 3. The majority.
And then they have the option, are you happy to accept them
Yeah.
under these circumstances?
Okay.
And depending if they've worked in that, they may not have seen that, but they may have worked in that area before
Yeah.
and have experience of working with that age group maybe.
Because you get similar RMNs that go to the children's hospital, don't you? Currently, so.
Big question. Why do you ask whether they're in a side room or not?
What is a side room?
I think there is so nurses going in to do very long shifts doing one-to-one specialing with patients that might be at risk of self-harm, and if they're in a side room and they've got no one to support, then they physically can't go to the toilet for the entirety of their shift. And so it's about whether they then need a 2-to-1 specialing instead.
Also side rooms where you're like in a
In a room,
separate
on your own.
from everyone else.
Separate to the ward.
And obviously if you're doing a one-to-one then,
And if the patient's like at risk of being violent and you are in a side room and you can't call for help because no one will hear you.
So usually they're in a side room when it's a little bit more acute. Or not necessarily.
Not necessarily. It depends if there's a side room available, isn't it?
So if they say they're in a side room, would you go leading with the question, do they need to go on 2-to-1s instead?
Yeah, just kind of find out if there's other support for the nurse that's going in and see if they're going to get a break.
I think the other important question if they're in a side room is whether they'll take a male or a female, and often the male staff if it's a female patient, will feel very vulnerable in those circumstances. So it's usually our RMNs that say, I wouldn't put myself in that situation.
That risk of all sorts of allegations, and it happens, doesn't it, all the time?
Yeah, especially if they're not in the best frame of mind.
So the forensics patients, they're in a hospital.
So forensics, yeah, forensic means they've committed a crime
Whilst,
with their mental health disorder.
and then forensic rehab.
So it's rehabilitation into the community.
Okay.
So you also have crisis teams. There's
Yeah.
a new reference which has come up recently.
Yeah,
Um,
that's in the
more special. Oh, right.
community.
Sorry.
That's all right.
I took a shift yesterday and it was quite complex. It was someone that was going to be in charge of their acute admissions, so they had to have experience of working in a crisis team because they might have to do assessments. But they were also just in charge of their admissions
Yes.
unit, so it took a lot of clarifying. Yeah, just to
Yeah.
make sure we got the right person.
Did you find someone?
Yeah, and then there was a band 5 that knows the ward really well that was going to do the shifts. So the nurse that took the in charge assessing role just wanted that reassurance that if he was in the middle of an assessment, there was someone else to support on
Yeah.
the ward while he was doing it. So yeah, everything was fine.
The mother-baby units, I don't think we get that many shifts for mother-baby units, do we?
No, never. Rarely seen it.
So Leeds had an interesting one a few weeks ago at a children's hospice, and they wanted an RMN. The baby was dying and the mum had mental health issues, so they funded for an RMN to be in with the mum to support her
Wow.
through it.
That's nice.
That was a different
PICU, is that where they've got like,
psychiatric ICU.
so that's when they're really, really severely mentally ill, not when they've got like, they're in ITU and they're also mentally ill.
No. And because PICU in most hospitals is paediatric intensive care, and PICU is psychiatric, so you just have to be really careful of what you...
So you are unlikely to get older people in the PICU unit.
No, you can get
Like, I
any
mean
age,
dementia.
can't you?
Yeah, anyway.
Depends what type of mental
Yeah,
illness they have, maybe, yes.
Yeah, it wouldn't be, you wouldn't go in to a PICU if you had dementia, you would go into a specialised dementia unit.
It's more like, for example, if somebody's been violent or aggressive in any way, then they go to PQ. Because I worked in an acute ward, so any of our patients, so it's PQ is like higher up, an acute setting. So if somebody's been violent or aggressive or anything like that, if it's staff or if it's other patients or anything like that, and they've been like in seclusion or anything like that, and you've higher seclusion, you go to PQ.
Because it's a higher staff ratio, isn't it?
Yeah.
Like intensive care.
So if someone had dementia, they normally are on an EMI unit, but then they have like the psychosis and it's been really violent and they're really, really sick for a period of time, they could go with you.
Not necessarily. Do you say if they're violent?
Yeah, like they've got some kind of psychotic episode and they're being violent and at risk to themselves and others because they end up on PICU.
Because I've never been on a PQ.
So they might be on constant observation.
I think it depends with the age range, because I'm not sure what the age range is for PQ.
Yeah.
But I guess it depends with their vulnerability as well. And yeah.
And what setting they're in originally.
I think that needs to probably be assessed closely, but it's rare that you find. But normally, anyway, dementia patients are normally taken care of in dementia setting, and they're like support available in dementia wards anyway.
Yeah.
To support with that, because I've never seen an older dementia patient who's really aggressive. That's really rare.
Well, not on mental health aggressiveness. So,
Yeah, because they would be really vulnerable in a PQ setting themselves.
mental health sort of community. So you've got your community psychiatric nurses and your crisis resolution. So in ad hoc, their mental health and LD packages have gone through the roof. So recently we've had one, which is finished now, but we've had one who was a Court of Protection, PHKA, Court of Protection, and was a 5-to-1, so 1 RMN, 4 psych HCOs 24/7 in a house. And she, because of her Court of Protection, she was only allowed to be cared for in this bungalow. She was locked in, she wasn't allowed out.
Why?
Because she was just danger to herself and others.
Mm-hmm.
And then we took her. Her previous provider walked out, so we got it up and running within 2 hours. Took her on the Friday night. On the Saturday, the sewage pipe burst in the bungalow and spewed all over it. But because she was under a Court of Protection, we had to get permission from the judge to move her on a Saturday.
Why from the judge? What has she done? Like that?
No, she's Court of Protection, so it's she's under a protection order.
Was that for her own safety, or was that more for other people's safety?
Both, yeah. So the types of section. So the one that I need to add is the section 5.2. So section 2, you can admit someone without their agreement for 28 days for assessment. Section 3, you can keep someone admitted for 6 months for treatment. Section 17 is the one that we see a lot in the kind of call centre on nights. So anyone who's under a section 2 or a section 3, if they require medical treatment and have to go to a general hospital, then they have to put under a section 17 to leave to go for their treatment, and then they can come back to go back onto their normal section. So we see that quite a bit.
So the section's very specific to where they've been sectioned. The section will determine they can only be in this one place.
What section? I have a lot of section 5.2.
5.2, yes, that's one that I need to add. So section 5.2 is it's for 72 hours, isn't it? 72 hours. You're not allowed to appeal it.
That's the doctor's
Section.
So the doctor can section you for a certain period of time,
72 hours.
And that's basically like an assessment.
For assessment.
Period. So that means you can be assessed for section 2 or section 3.
So if someone was to have like, if
Complete
someone
breakdown and
so if someone section 5.2 would be seen as someone who like doesn't really have previous mental health issues, something's happened to them or whatever, and they all of a sudden have like a massive breakdown, or they try and kill themselves or something, then you got put on section 5.2. But if it was someone who had like mental health issues for a long time, and they
can still go on the section 5.2, couldn't they?
Yeah, it depends whether there's a doctor available.
Yeah,
if there's only like a nurse available, then a mental health nurse can fight for them. So that only lasts for 6 hours, and then they need to be seen by a doctor, which can fight to them. And then, unless there's like a mental health doctor, sorry, not a mental health doctor. Basically, there's like 3 people that can section someone, like 2 doctors and someone else. I need to remember that name. Basically, 3 people need to be able to section someone for 2 or 3.
Okay, but what I mean is if someone called up and said, oh, they're under section 2, it's most likely someone who has like quite has had mental health problems very stiff.
No, not necessarily, because you could be on the section 5.2 for 72 hours, and then they move you to a section 2 or 3.
Okay.
So it could be the first time or the 10th time.
Yeah. The section 136, we're seeing that more and more, particularly in community. So that's a place of safety order from the police. So they've got a specific 136 suites. So sometimes they're attached to the police station, sometimes they're attached to a general hospital. And what we found is since they changed the Mental Health Act, and that particularly children aren't allowed to be put into custody as a place of safety anymore, they get moved to these 136 suites. So the kid in Plymouth that I was just talking about, the 5-to-1, they were going to put her in a 136 suite when her other provider walked out, but it's actually only they were saying it's only two 136 beds in pretty much Devon. So they'd have to transfer her miles and miles.
It's Southwich Hospital, isn't it, in Bristol?
Yeah, they've got 136, haven't they?
So we do get quite a lot of requests now, police stations as well, to provide RMNs. On a
Yeah,
weekend, if somebody's been taken into custody.
and there's no one else available.
I remember doing night shifts and getting the call from the police station and calling a mental health nurse at like 3 o'clock in the morning and describing that someone's violent, and the nurse is like, cool, I'm on my way. Wow.
Yeah.
Amazing.
Yeah, it's very impressive.
Yeah.
And that's the difference between the psychiatric nurses and the general nurses, is that we can call psychiatric nurses at any time,
Yeah.
24 hours. They
It's amazing,
do.
it's such a difference though, isn't it?
Yeah.
You know that mental health nurses obviously, I mean, I'm not saying that general nurses don't either, but it just seems they are so much more accommodating because of...
They travel anyway, don't they?
Yeah.
They think nothing of travelling 3 hours.
But then you've also got to think that our mental health nurses have a much smaller selection of work. So like our
But it's still so down,
but I feel like our general trained nurses are so used to having so many shifts on the system that it's like they can't afford to be picky. Like they can get called at 6 o'clock in the morning and think, "Do you know what, like I don't want to be called this early, I don't want to travel there." Whereas the mental health nurses, they're in an agency that pays higher than us, and there's like maybe 1, 2, 3 shifts on a quiet day compared to how many you've got. They can't really afford to be picky.
Well, they could, but they don't tend to be as much as
They tend to be more compliant, don't they?
Maybe it's the nature of the work. My friends who worked in mental health, I mean, they go into their day at work and anything can happen. And that's just the nature of the kind of work they do. So getting a call at 3 in the morning to go to the police station, they're like, yeah, that fits into my day of work. Because anything can happen. Yeah. I'm not doing med rounds on it.
No.
Yeah, it's different.
That makes such a difference to the patient as well, doesn't it? You know, having somebody there. If you're in a mental health state, it's just knowing that somebody's there makes such a difference.
It does.
I think one thing I find really confusing is if the patient has been transferred from a psychiatric hospital to a general hospital, say an AWP hospital, and they come into a general hospital, can we put AWP nurses in with them in a general hospital? Because the stay in hospital is usually quite limited, so then when they have to do the transfer with the AWP, they can't go back into an AWP unit.
Oh, I don't know.
So AWT. Wiltshire Partnership.
Yeah.
Because also does the hospital that's looking after them, the general hospital, they're the ones covering the
That's the other
cost
thing. Who's
of
covering the cost?
looking after them in that moment.
What
Well, they're
happens
not.
in terms of AWP is that they can only take care of the patient for 24 hours. After 24 hours, it's the general hospital's one-to-one in the patient, so they need to arrange for one-to-ones, if that makes sense.
Then that comes directly
So
to the general
we are
hospital.
like, yeah, that's it. We can only provide support for the first 24 hours.
In the general hospital, so they'll send
Yeah.
staff. to
We will be
cover
sending
everything.
staff to the general hospital in a mental health ward, but only for 24 hours. And then we did give them like, oh, after 12 o'clock tomorrow, we're not going to be supporting you anymore, so you need to look for staff after 24 hours.
Because
it's a
AWP can't
20
be covering their own wards that staff's been sent from.
Because I'm guessing after 24 hours, we are going to have to use our bed for someone else. Because they potentially have 2 beds available that they're using, one over at the general side and one over in the mental health hospital side. So yeah.
They can't hold 2 beds at once.
Not fair.
It's similar in the community. If you have complex care patients going to hospital, we can normally continue to provide care for 24 hours, and then the hospital staff have to either pay for us or find their own staff. And it just, that 24 hours gives time for sort of continuity care, complete handover, getting the patient settled in the new environment, and then
They can get support in the general side from like the mental health team inside the A&E, inside the general hospital, with like psychiatric
liaison.
liaison
Yeah.
services,
Yeah.
which they can provide support then in the general hospital.
Learning disabilities. So we've had, as the same ad hoc, had a massive increase in providing autism and Asperger's packages of care. And I don't know why they've suddenly increased, but it's just gone crazy. Non-verbal autism to people, who can completely communicate. So Ello, she's autistic, she can communicate, but she needs 3 people to kind of manage her behaviour, and she has to have 3 males because females can't physically hold her, she's that strong, and which isn't difficult for them because she likes to take her clothes off, and she likes to phone you guys, which she used to phone up and have a conversation with you.
What's non-verbal autism?
So when they're autistic, they can't verbalise, can't communicate.
What, like they physically can't speak, or
They just don't know the language, can't
We
they?
kind of go good rather than no. Or,
I can remember when my dad first remarried, his wife's had a 24-year-old who was like severely disabled, but also autistic and like you said can't speak, and because there's like no facial expression and there's like no communication, when I was like 9 it was absolutely terrifying because I constantly, when she like flaps about and knocks things over and stamps her foot, I used to constantly think like she's really aggressive, but she's not, she's just
That's how she
that's how
communicates with
she
you.
That's how we're
communicates, and
communicating, isn't it?
really she's probably like really happy. A lot of the time it's when she was overexcited when she got offered a cup of tea or a biscuit, but when you're like 9 and you've never experienced that, I used to just genuinely think that she was absolutely livid 24/7.
Yeah. School nursing. There's mainstream schools, special schools, we shouldn't be calling them that, but I couldn't think how else what to call them.
Like St Christopher's,
Yeah.
they deal like primarily with people with complex
Yeah. Private schools, independent schools, boarding schools and academies. And they generally go on the system, don't they, as S-spec, isn't it? S-school spec? S-spec? Yeah.
Yes, but yeah, because there's some, like a private school, isn't there? There's some recently.
We've got a couple, haven't we, that boarding schools that need
Yeah.
nurses. But Rika's put together all the kind of duties of the school nurse and Tanner searches, etc.
This is an area I've not known
For you
anything
to
about.
look through.
Yeah.
Is it quite unlikely that we'd actually get a like a school nurse in a state school? Because I can just remember what like if I ever wanted to pull sick in, you'd have to go to the nurse's office and she wasn't in. We didn't ever get a replacement one.
But then they do like immunisation programmes and all sorts, don't they?
Yeah.
back in the day,
You have a
still,
team that goes around different schools now, rather than a school nurse in one city school. They go around lots of schools. A team for Bristol that cover all the schools
Okay.
and do immunisations, but then another team for school sort of health.
Yeah.
And then I just put some of the slides from the ad hoc training just to kind of give you a bit of insight into it. So ventilation, so basically it's when a machine breathes for you or assists you in your breathing. And there's 2 main types of ventilation: invasive, which is via a tracheostomy, or in hospital it's via a ET tube, and non-invasive, which is via mask or nasal cushions. And as a general rule-ish, invasive ventilation in the community needs to be an ITU nurse, generally. You can't go wrong if you put an ITU nurse in, whereas non-invasive can be a non-ITU vent-trained nurse as a general rule.
How do they do an invasive one?
Tracheostomy.
What, they put a hole in there?
Yeah, I'll show you a tray. I've got a trachea in a minute. I'll show you. It's a hole in.
And then
Non-invasive mask or nose.
what, and you have to pump that thing?
Are you looking at the hand ventilation
Yeah.
below? Yeah, that's slightly different.
Okay.
Yeah, you'd have to do it all the time. Your arms would ache.
You have to do that all the time.
So you're on a machine that does it for you.
Okay.
Will invasive
No, right.
include intubation? Is that
Yeah, in
ET?
hospital. Yeah, yeah. So these slides were very much for the ad hoc. So it's all about community. Hand ventilation. So this is for people who need ventilators to be able to breathe, and when they come off the ventilator, you have to hand ventilate them. So I did my first clinical shift on Sunday, looked after a trachea, fully ventilated, hand ventilation, cough assist. It all came flooding back after about 2 minutes. I go, oh my God. So yeah, the difficulty with children with your hand ventilation is you need to use a paediatric ambi bag because it has what's called a blow-off valve on it. So basically, you can't give too much pressure into the child's lungs. But nurses in the community have to do a lot. You have a lot of responsibility.
Yeah, it's all on them, isn't it?
So there's a tracheostomy. So the picture on the left-hand side is what we call a bivona flex end.
Okay.
That's right. So you can see on it, let me show you. So children don't have necks. So they just have chins and chests.
Oh.
And it's not until they grow that they actually grow a neck. So if you've got a trachea there, you end up with real pressure areas under their chin and stuff, and they can include their trachea with their no neck. So they have flexi ends, so that's against their neck, and then that bit comes out, so it's out here. So you can have the ventilator tubing without anywhere near their chin. So they often have those, and then that's just another type of Shiley. It's really it's fairly simple to change trachea, particularly with kids because they have a lot of glob, but you have to be prepared. So a laryngectomy is completely different to a trachea. So when they have a laryngectomy, all their upper airways have been disconnected from their lower airways. So it's completely irreversible. You can't ever reverse it. Whereas a trachea, you can wean them off and.
Can it grow back? Can it? The hole grows over and you can.
With tracheas, yeah.
Yeah. So the actual windpipe repairs as well, does it?
Well, it does, yeah, because it's just a whole.
You pull it out.
Yeah,
I suppose if you think about earrings, you take the earring out, and if you let it too long, it grows over again. But how long would it take for your windpipe to grow back?
So if it's a brand new trachea in kids, they can close in 2 hours.
Wow.
No.
Yeah, so that's why they do the first 3 trachea changes in theatre.
Because they have to do it that fast.
Yeah, and they're so sleeps in case they need to put dilators in and hold it open.
Wow.
Yeah. But
why would they, in what circumstances would they have to remove the upper airway from the lower
Cancer,
airway?
generally.
So their throat doesn't work anymore.
Yeah. So you see the old men walking around with holes and
So that's a
and having a fag
laryngectomy.
and the smoke's coming out the roll.
And they can't speak anymore. Yeah, that's how intense.
Yeah, they can't speak. So they go right there. They go. And some people have little tubes in it like that, or little buttons.
I get one of them from smoking.
Possibly. But then, with kids with tracheas, siblings would disconnect their vent tubing and shove tissue in it, or shove Lego down their trachea, or
Why?
because they're kids, aren't they?
Yeah, kids do funny things.
Because I can.
They
So
don't-
that would just go straight into their lungs?
Well, you kind of don't. You get to them before they shove it any further. So yeah, the joy of a community. Right, assisted cough and cough assist. So this causes great chaos in community. So basically, what we need to know is assisted cough is without a machine, so with people, whereas mechanical cough assist is via a machine. So the way that a mechanical cough assist works is that it gives you sort of 3 big breaths in, and then on your last breath it gives you a negative pressure to make you breathe out really, really, really quickly. So go on, who wants to volunteer? Take 3 deep breaths in, and then on the last, no, don't you do it because you'll wheeze like hell.
Wait, what do I have to do?
Take 3 deep breaths in, and on your third breath, go as far as you can.
I've done 4.
It doesn't matter. It doesn't matter how many breaths. It doesn't matter.
I feel lightheaded doing that.
Well, just take 1 deep breath in and breathe out really quickly until you can't breathe anymore. Keep going.
I can't.
Generally, it makes you cough.
Oh my god.
Exactly. Yeah. That's basically how it works.
So like creates a
Of course it's-
vacuum
Yes.
next to the pressure and it like drags
Yeah.
that and
And then you cough.
Yeah.
So it's for,
Clear your
so it's for
chest.
people that can't cough. They haven't got any muscle tone to cough.
Why do you need
Wow.
to cough though?
To clear your secretions.
Clear
Clear the
that
glob
flooding.
out you. Yeah, that stuff. So the kid that I looked after on Sunday, he's on the Nippy Clearway. So they're preset. So he has 20 cycles and it does it one dun, 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 until he's finished, and then he comes off, has a suction and goes back on the vent. So yeah.
So does it 20 times? How often?
His
in a
his
day?
so he has his 3 times a day, but it's like, it depends, very much
Yeah.
depends on the patient. But yeah, he has 20 cycles, so it's all preset. And then then he comes off and goes back on his vent, and you literally put it on, press start, it does its thing, it beeps really loudly when it stops, and then you disconnect and pop him back on his vent.
Can you overuse a cough assist?
You can do.
Is it only
Can't
is
over
it
rely on.
prescribed?
It's
How?
prescribed,
Yeah.
the cycles, yeah.
Right.
And generally they say you can have 3 times a day of however many cycles they've got. When unwell, up to 6 or something.
Right.
And if you need more than 6, then you have to get medical attention. There's generally a protocol in place. So that's the Nippy Clearway, which is all preset. And so you just put it on, press the button. On the left is one of the older machines where you literally had to use the dial. So that's why with different skills, there's preset and non-preset. So you literally have to go in, out. Whereas, and there was such tiny little dials that it was a massive error that you could whack and give them a massive pressure without actually realising. Which is why children have only been having cough assist probably for the past 10 years. It was always an adult thing because their lungs are so horrible and their chests.
Which sort of patients would get this? Is that like cystic fibrosis or is that anything?
It tends to be your muscular MNDs,
Right.
your spinal muscular atrophies, the ones that have no muscle tone, spinal patients that are
Okay.
paralysed,
Yeah.
that have no muscle
Yeah.
tone,
That just helps them get rid of all
or
the
their crud.
basic crud
Yeah.
in the throat, yeah.
Yeah. You have your ventilator. You can have different programs. So some patients have one for the day, one for the night, one for the day, one for the night, one for their poorly. So program 1, 2, and 3, and you can up and down. Some patients they say they only had one program, but if SATs were below such and such, and you were on so much oxygen, you could put the PEEP up to whatever.
Yeah.
But, oxygen saturation monitoring. So that's when you measure the level of oxygen in your blood, and it's through an infrared probe that goes on your finger, your ear, your toe, and it counts the amount of red blood cells floating.
Your finger.
We don't put it through your finger, you clip it off. The infrared light
It's like
goes
just
through your
impact
finger.
light, isn't it? Yeah.
Yeah, but that thing looks like
A needle, doesn't
yeah. So when you stick it through the finger.
Oh no, that's the lead.
That's the lead.
Yeah, yeah, it doesn't
I
show
got
the
it,
brick.
It attaches to those probes there.
Okay, that's fine.
You can have peg ones.
Peg ones, yeah.
The difficulty with these probes is they get quite hot. So in particularly in babies, you have to change their site every 4 hours. I've seen some horrendous burns on fingers and digits from it because it's hot.
And is that a skill? Is that something we have as a skill? Or is that
No.
part of
No.
that's
It's
part
just
and
part of
parcel of
it,
just
Nebulizer therapy. So nebulizer is a inhaled, basically mist that you can put medication in. So sometimes you just have normal saline, which is a salty water that then just reduces the thickness of the secretion, so it's easier to suction it out. Asthma medication can be nebulized, but the one that we need to be really careful of is the antibiotics colomycin and tobramycin, particularly tobramycin because it's toxic for fetuses. So if you've got pregnant workers, we need to be really careful. And basically they can't administer Toby. They can administer colomycin if they're careful, but they can't administer tobramycin. So when we got the ad hoc clients, on their status it will say colomycin, tobramycin, make pregnant workers aware. Because it does.
And then if there is, I mean, I don't work in the ad hoc team, but if there was a nurse going in there, they would know.
Yeah,
if
they read it out. Yeah, it's colomycin or tobramycin.
Because they might not say necessarily that they're pregnant.
No, and
Early days.
then they get the option to say
Yeah.
yay or no.
Okay.
Yeah. Sometimes, I mean, a lot of kids with long-term sort of lung conditions or colonised with in their chests, kids and adults. Pseudomonas.
Right.
So if they're colonised with Pseudomonas, they end up on a colomycin, tobramycin. Right, bowel care.
So with the bowel care, there I did some support work, and there was a whole other kind of bowel care, which was using
Kerosene.
Laxido,
Okay.
and that kind of did. It was a woman who had MS, quite
Yeah.
advanced, and so 3 times a week she would have Laxido in the evening, and then the next morning she'd have a suppository.
And then it would work.
And then it would work.
Yeah.
So this is when that doesn't work. This is when.
So this is
It's
when
all
you need
stopped.
physical
Yeah.
help to. So yes, digital stimulation and manual evacuation when you put it up and hook the pill out with your finger.
Oh, that's what you're
Right, moving on. Right, so there's four types of catheters that you use in the community. Indwelling catheter, so it's a catheter that goes up your urethra and stays in and is changed generally every 3 months. Then you've got an indwelling suprapubic catheter, so that goes in from the outside into your bladder. And then you've got intermittent catheterisation, where you literally pop the catheter in, drain the urine, and take the catheter out. And then you've got penile sheath, which is the picture on the left-hand side.
Why would someone have a penile sheath rather than a catheter?
Why don't they always use the one, what's it called? The sheath?
Why don't they always use the sheet?
Because their
if the
penis.
man's
Infection.
Yeah, hygiene's probably a big issue.
hygiene's probably a big issue. Yeah.
So how long you use it for as well?
Yeah, so maybe a penile sheath, they just need it temporarily because they're dealing with some issues.
Or geriatrics use it quite a bit, don't they?
They use it for surgery though, don't they? Like when you're going to be in like surgery for a long time.
They generally catheterise, don't they, as opposed to...
Yeah, otherwise
That's what I mean, but they use that
You're
bit.
more likely to put an internal catheter in temporarily, but long term
Oh,
you
right.
might go for a
Really?
sheath, because each time you put it in, you're running the risk of taking an infection.
Okay,
Yeah.
so if you have
Up
to,
your pee hole.
but you wouldn't be using an indwelling urethral. So it,
You can do, but
Yeah.
yeah, it's generally personal choice, isn't it?
okay, yeah.
And sometimes with men, obviously, their prostate drops as well. And so if you take a catheter out, it's very difficult to put it back in again.
Yeah.
So that's
Supported someone who was the same woman, and she had a suprapubic catheter as well, and it just leaked all the time.
Oh, really?
It was a nightmare.
Mm.
Yeah, she was quite heavy, and I think
I
it
think
just
cat-
sat under the
catheter
upper
thing
way,
just
Yeah.
looks
and so it just always
extremely
pushed
painful.
the tube out.
Oh,
the
yeah.
way,
I can
and
imagine
then
that
it
being
was
really
like-
hard to actually fit. Like one of those things, like as a nurse, like I think I'd much rather.
Sometimes they do them. They have to do them in hospital. It's not just something you could potentially. Depends on where, because obviously the prostate can drop so much. It's very difficult to get up. So it's they have to take it back into hospital to.
I don't know what
yeah.
any of these terminologies are.
Don't put it up there.
Yeah, that's quite
For
special.
indwelling, but not intermittent, because the intermittent catheters are so well lubricated that it's much easier to.
Well, they don't lubricate the indwelling when they get
But
it.
they're bigger. There's also mitrophilophs as well.
What's that?
So mitrophilof is a surgical channel from the bladder to the outside with a little button on it, and then you just catheterise through the channel.
Alright.
A lot of kids have mitrophilophs. I like saying the name.
And they
So
keep the catheter
what's that
in.
one there?
No, just
Figure
take the catheter out,
one.
close the button.
that's the whole
All right, so
That's a
release the
super
urine
bit.
and then close it up.
Yeah.
A friend of
that's
mine
like
is
a hole
a
that
doctor
they
and
make.
she works in female
So it's not
urology and
coming
they're
out
looking at
as
Thing
it
is, you
normally
can't
is.
feed it when
Yeah.
you get a
to help
catheter
with
fitted,
incontinence.
can you?
So women who
Not
have,
that
yeah, and it
now,
makes
no.
sense,
It
right? The
does.
pacemaker can
Might
keep
be.
your
Oh, they
urine
don't
on
give
a
you any
constant,
anesthetic.
like
Yeah.
rhythm, and so they know when
What
to
hell's
anticipate
mad?
in the toilet.
That would be
See, if men had
That's
been
a
in
bit
charge.
More painful.
Exactly.
So,
So neurological, epilepsy and seizures and spasms. There's all different types of seizures, and that's not a full list by any stretch of the imagination. Spasms are muscle contractions that often people think are seizures, but they're not neurological related. One of my old packages, Songe. You remember Songe? don't you?
Yes.
Her spasms, she would corkscrew and her heel would hit the back of her head.
Wow.
With her spasm. So she'd twist. No, I can't, obviously I'm not that bloody couple, but yeah. And the way that they thought she was going to die was by breaking her neck, but thankfully she didn't, but she did die with respiratory issues. But yeah. Spinal cord injuries. So they can be related to trauma, they can be related to a tumour or a lack of blood supply. And depending on the level of your spinal cord injury to what care you would need. So the next slide shows you where your spinal injury is. So the red bit is where you're paralysed from. And then depending on where you're paralysed to what you would need. Acquired brain injury. So the highest rate of ABI in the UK is Northern Ireland, and I think that's from drinking and fighting. But you'd also get hypoxic brain injury and traumatic brain injuries. So in PICU we used to get the shaken babies. They used to come in with brain injuries from being shaken.
What's an acquired brain injury? An injury caused by the brain since birth?
Yeah.
So after you're born?
So yeah, it's not, yeah. So we used to get the shaken babies. Yeah. Falling off a horse.
That's why it's so important to have things like
cycle helmets
and skiing when you're skiing now as well. Because obviously you hit a clunk of snow and you back to back of your brain, and of course your brain swells.
Yeah.
Yeah, I just think there's so many things I could get stuff like that.
Yeah. But that's what, what was her name? Liam Neeson's wife, Natasha Richardson. She wasn't wearing a helmet, fell over on a baby slope and died.
Yeah, she did, yeah.
In her 40s.
Yeah, but you hear all these stories about stupid 19-year-old boys going to the pub and getting in one fight and getting punched, and it either hits a certain part of their jaw because you've got nerve points all the way down there, haven't you? Or falling on the floor and hitting their head once, and that's it.
That's it. Gastrostomies. So when people can't eat or drink and they're fed through a tube into their bellies. So there's different types of gastrostomy. A PEG, which is put in by a surgeon. RIG, which is put in under radiological view. A Mickey button, which is the picture there, which is a low profiling button that is kept in by water in that balloon, which is the picture above, which a lot of kids have, and slim adults. You can't have it if you're a bigger adult because they're not long enough to get through your subcutaneous fat into your tummy. Also known as G-tubes, they're all different names, and they have to be twisted every day just to stop them granulating. And yeah, you can feed through it. A jejunostomy, so if they're not absorbing into their tummy, they can absorb into their small bowel, into their jejunum. So the tube goes into their jejunum to be fed, and they absorb much better.
Is that effectively then below the bowel or above the bowel?
Above the bowel, below the stomach.
Yeah.
Yeah. And they sometimes have G tubes and J tubes, or sometimes they can have a GJ tube, which is the same, just have different ports, and one goes into the stomach and one goes into the jej. And sometimes they're fed by the jej, but have to have medications by their stomach, or they have everything by the jej, and their stomach is on free drainage. You could also have these tubes from down your nose, NG or NJ tubes. And the way you measure an NG tube, it was the tube from your nose to your ear to your belly, that was your NG. And then your NJ, nose to your ear to your belly to your hip. And that would be the length of your tube that you needed to put down.
So do nurses have to put that in?
Down, yeah. Yeah.
So this might sound a bit daft, but do you actually have to get a tape measure, or do you just get a length of tube?
So the tube has got measurements on it.
Oh, okay.
Yeah. So you can see the little dots.
Is that easy to fit?
It depends if they're screaming or not. If they're quiet, it's easy to whack it down. The NG tube you can test by withdrawing fluid, and it's on a pH stick, so if it's acidic, it's in your stomach. The NJ tube, they often do it under X-ray to check it's in the right position, but we used to put food dye down the NJ tube and then draw back on the NG tube, and if the food dye came up the NG tube, then it was still in the stomach, not in the in the jejunum, but you never use red food dye because it makes the doctors very twitchy about abdominal bleeding. Bless them. And then if all that fails, you can have total parenteral nutrition, which is basically you're fed through a vein, which is very miserable. So you can't eat or drink anything, can't feel full, it's all fed via a vein. And it's fed through a central vein. And actually they get to the point they either have to have a gut transplant or they run out of central veins to have lines in. So, but yeah, it's not a life at all.
How do you put what? So you actually put a line through a vein?
So they have a line inserted into a deep vein, and then you connect it to the line.
Okay.
Basically, they get fed the vital nutrients and things to make sure they have enough,
Yeah.
I suppose.
But yeah, not a life. Routes of medication, they're all your routes of medication. Obviously this is for community, so I've put oxygen as a prescribed medication, enteral feed as a prescribed medication. But they can, buckle is in your cheek.
Why would you put it into one's cheek?
Because you've got really good blood supply, so it absorbs really quickly.
Oh.
So you put epilepsy meds, some epilepsy buckle and Daslam into your cheek. Sublingual under your tongue. So people with angina have sublingual medication. Intranasal up your nozzle.
What was the other one, sorry?
Sublingual under your tongue. Topically on your skin.
Oh. Wait, what was
Topically on your skin.
on your skin?
This is your last slide, everybody. Like infusion pumps. So there's all different types of infusion pumps, and there's all different types of how you give the medication in it. So you can have a continuous 24/7 infusion where it just continually gives you medication. You can have intermittent that just goes over an hour or 30 minutes or 20 minutes. It can go subcutaneous, which is under your skin, or it can go intravenous into your vein. They can be locked, they can be open, and they can be patient driven. So a lot of nurses, you'll get a client say, well, they need to be competent in a Laris pump, for example, but a lot of, sort of ITU nurses will all have a Laris pump experience. Depends on the area of the country and what they use. So the locked, obviously pain relief, so in the community they can't be tampered with. Open are like the pumps in the middle, and patient driven is where they can give a boost themselves. So, but that is it.
Thank you very much, Kate.